See everybody. We're going to start here in just a few minutes. Welcome to our third Cobra rounds. That includes both the Cole Institute and the Byers Eye Institute faculty and retina fellows. Sunil Srivastava here, my partner in crime, Prithvi Mithranjaya at Stanford University. Just say a few words from our host and sponsors. Brett Bausch and Lomb has been supporting our series here. They just wanted to thank them again for the support for running this innovative series. We think we've gotten some really nice feedback for our first two. We're gonna try to continue it here. A couple of housekeeping, just if you wouldn't mind, if you aren't, just make sure you're on mute. Yeah, and then we're happy to interact with those who want to interact, and put something in the chat, and that way we can all discuss. Our fellows are going to present, and we have our faculty members who are going to lead discussion. Prithvi, take it away, bud.
Hey, Sunil, I think we have some new members of the retina community in our midst. I heard there was a match last week.
We do, that's right. And congratulations to all those who've matched. Welcome to the family. One day you'll end up like Prithvi Mithranjaya, for better or for worse.
And if you write him a check, Sunil Srivastava will be your friend. So it's
I do have a Twitter handle, and my Facebook, my TikTok page is fire, as I've been told by my son.
No one follows you. Okay, so our first, so we'll get started today. So the theme today is lens-related surgical experiences, and we have some really great cases today presented by two fellows from Cole and two fellows from Byers. And again, for young fellows and residents and others out there, it takes a lot to share your surgical experiences with others, especially if it doesn't work perfectly the first time. But I think these cases represent some excellent teaching opportunities, and we appreciate our fellows for putting themselves out there for us to all learn. So we'll start from the West Coast side. So our first faculty mentor today is Dr. Carolyn Penn. Carolyn is one of my partners here at Stanford, where she's a clinical associate professor, and she's the chief of vitreoretinal surgery at the Santa Clara Valley Medical Center. She's a esteemed product of the University of Colorado for residency and did her fellowship at Jules Stein. Carolyn teaches our fellows at the Valley, and they do only the toughest of cases under her tutelage. The first case will be presented by one of our first-year fellows, Charles DeBoer. Charles did his MD and PhD at the University of Southern California, and it's been a delight to have him here with us over these past 6 months. So take it away, Carolyn, and good luck, Charles.
All right, thanks, Prithvi. Charles, you want to pull up your presentation for the first case?
All right, good. Do you have it?
Yep.
Okay, do you want me to start out?
Yes, go ahead.
Okay, perfect. So I'm Charles DeBoer, as you guys know, coming from Byers Eye here at Stanford. I have no relevant disclosures. And this was a patient who we had seen. This was a 70-year-old woman with 7 months of decreased vision in the left eye, which was felt to be worse in the morning. She'd been worked up outside by an outside ophthalmologist and was found to have this recurrent vitreous hemorrhage and hyphema. And she also had like flashing lights associated with these symptoms. In terms of her medical history, she had AML with bone marrow transplant in 2009, graft versus host disease of the skin, had been treated with Rituxan, and also had ocular graft versus host disease, previously on Restasis and autologous tears. She also had a history of cataract surgery and intraocular placement, lens placement in 2013. We didn't have any notes from that prior surgery, but it had appeared to be non-complicated. Examination, the right eye is 20/30, pressure was 16, and the examination was normal. The left eye vision was 20/70, pressure was 17, and there was some injection, inferior endopigment on the cornea, and 3+ mixed cell and pigment, as well as an area of superior vitreous prolapse around the lens. The lens itself was in the bag, but there was an inferior tilt, and there was some cell in the anterior vitreous as well as a Weiss ring. This is a fundus photo of the patient, and there's some inferior vitreous hemorrhage that we're seeing. Optical coherence tomography, the fovea was flat. And we did fluorescein angiography just to evaluate for any sort of vasculitis, further workup. And the fluorescein angiography of the left eye was normal. There was no abnormal leakage or vasculitis seen. So on UBM, here's a vertical axial, and you can see that the lens is tilted. You can see this area of superior vitreous prolapse, and which have been noted on examination. And if we look at the R6 and T6, it's a little difficult to see, but what we were seeing, especially when evaluating the patient at the ultrasound itself, was it looked like there was rubbing of the haptic against the ciliary body itself. We did
So
speculate.
Charles, just to stop real quick. Did you guys consider getting an anterior segment OCT in addition to UBM?
We didn't. I think that would have been a good thought. I don't know if we would have been able to see. The UBM gave us a nice depth of looking at the ciliary body itself, but anterior OCT could have been a good thought as well.
Yeah, I mean, I think for most retina colleagues, that's not something you have access to, but at an academic center where we have all of our other specialties present, that could have been something to consider.
Absolutely. We did specular microscopy, and the endothelial cell count was 2748, so she had a good endothelium that looked normal. And so at the end of the day, we have this patient with recurrent vitreous hemorrhage, which has been occurring for several months. And we felt this exam was consistent with uveitis glaucoma hyphema syndrome due to the intraocular lens contact with the ciliary body at 6 o'clock. And there's also this vitreous prolapse superiorly. And so at this point, it could be, you could think that maybe the vitreous prolapse was the majority of the problem, or maybe there was this contact inferiorly as well. So at that point, we decided that we were going to do an intraocular lens exchange. And the thought was given the fact that we had the, we thought that there was contact with the lens and the ciliary body, instead of going back and putting in a sutured lens, which potentially could cause similar problems because a lot of people do have these lenses and they don't have this type of problem. We decided to go with the anterior chamber intraocular lens. And we would do vitrectomy at the same time, taking care of the hyphema that's there, the vitreous hemorrhage that's there, as well as taking care of the vitreous prolapse.
Right.
Carolyn, you famously disagree with everything that I tell you that I do. Is this the right decision here?
To remove the lens and put an ACIOL in?
Yeah.
I was actually going to ask Sunil that question because
he's going to disagree with
your
me.
case.
How's the patient again? I'm sorry. Remind me. I apologize.
I think she was in her 60s. Yeah.
Yeah. I think you can tell the comfort with ACIOL is directly proportional to the number of gray hairs you have. This was our secondary IOL when we were younger. It was so much easier for us to do just because doing sometimes CZ lenses where it was cumbersome and you had a fair amount of tilt. I love the idea of an ACIOL here. I think it's a great idea and a great choice. I wouldn't say you're wrong for doing any of the lenses. You can make an argument, I think, positive and negative for each. So I guess I'd ask Charles, if I'm allowed to pimp another fellow, why would you choose an ACIOL and why wouldn't you choose an ACIOL?
Right. So we thought, in this particular case, we thought a lot about it. And we went with the ACIOL versus the scleral suture because we thought that there had been an issue with rub in the back of the eye. So if we put a scleral suture IOL in the posterior chamber and this recurs, we're going to sort of go back to the fact that we think that's happening again. So in addition, this patient has a good endothelial cell count. The anterior chamber is deep. So we felt that this could go in the anterior chamber and could do well for her.
So the difference though, however, is the lens was the rubbing, it was a one-piece lens, right? And it's meant to be in the bag. And then you also had that vitreous coming forward. So if you had actually removed it, the thought is maybe there wouldn't be rubbing because you're kind of removing some of that extra material. I actually agree with Sunil and Prithvi. I don't have that many white hairs or don't have any white hairs in my head, but I also love ACIOLs. I'm a big ACIOL lover. And I know it gets a lot of like bad talk from the retina community, but yes, it is a humble brag. My hair is all natural, thank you.
Okay,
But I
Vicky doesn't
actually
have any
really,
white
I
hairs
think
either.
a
is
good
mine.
ACIOL placement, a good ACIOL placement is, you know, just as good of a lens. And if you are good at doing a good scleral tunnel, and the new, you know, like the old generation ACIOLs have a lot of bad rep, but I think the new ones are fine, and they've been in existence since I was a resident, which is over a decade, so they're not even that new anymore. But anyways, let's let Charles get to the video, and then we can, I'm sure, have lots more to discuss.
Okay, so here's a video. So we're starting out, we're doing the superior paritomy, and then we put in the first trocar to put infusion in the eye. Now we're going to start. Okay, good. So now we start, and then we're going to start the scleral tunnel, but we're not going to go all the way through with the scleral tunnel. We're just going to get it started and prepared. So we're coming up here and going along and bringing it to the cornea.
I'm going to just have you pause right there, Charles. I think it's really important and really good that you put the infusion in first before you started your scleral tunnel, because yes, ideally you don't enter the eye, but many times, especially somebody who is not used to doing scleral tunnels, like the newer fellows, you enter the eye inadvertently or early, and having infusion and something to maintain the pressure is really important.
So now we're doing vitrectomy, and we do a core vitrectomy. The patient already had a PVD, but we checked for that. And then we're just removing the inferior vitreous hemorrhage. There are areas of retina that looks slightly atrophic out here, and we're gonna take care of that in a little bit. But right now it's mainly just the vitrectomy. Next, we come and remove PCO from the back of the lens. We also try and remove any possible lens fragments in the back. I'm not terribly, you might be concerned that the lens could fall in this situation, but the lens is pretty well, is in the bag pretty well. And the plan here is we're going to take the lens out, and then we're going to remove the bag capsule complex and remove the zonules to prevent anterior PVR after this. So we're cleaning up in the bag.
Sometimes those retained capsular pieces, some rings rim become a IOFB, and you can't chew them with a cutter. So it's a risk.
I agree. I think sometimes those end up being the hardest part of these cases, is getting at those really tough pieces. Like sometimes you can't even get them with a cutter.
You could argue just, getting the lens out and then leaving the capsular bag if you really needed to, or part of it.
And here
Or
we're
if you're making a tunnel, just take it out anteriorly as an IOFB, since you're going to have a large 6mm wound.
Good point.
so here we're going to apply sort of like a PRP laser to that area of atrophic retina. And now we're going to address the lens. So we haven't entered the eye, we haven't made the full scleral tunnel yet, but we're going to come and we're going to grab the lens and bring it into the anterior chamber. I had seen a technique where someone used a Sinskey hook and they kind of reached under the haptic optic junction and kind of pulled it anteriorly. And that's what I'm trying to do. First, viscoelastic, of course, to protect the cornea.
So Prithvi, I'm going to put you on the spot here, because this is a question I asked Charles when we reviewed the video, was what was the thought of taking the IOL out first and then the Sommer's ring capsule, or like Sumit mentioned, just taking the whole thing out in one on block? Was there discussion about that?
I just did whatever Charles wanted to do. No, I'm not sure we decided that. I think we thought if we could get the IOL out and prolapse it into the anterior chamber and take that out, then our goal was to get the entire capsule removed. I didn't want to leave it, which I could have. And I think the goal was to be able to, show how you can use a bimanual technique to get all the capsule out at the level of the zonule. So I
Mhm.
think that's it.
Okay.
Yeah,
I mean, I think it's nice to show this video because sometimes in UGG, we often see it. It's a one piece where like a haptic actually wasn't in the bag and it was in the sulcus. And you do take the IOL out and you want to leave the capsule in place at that time and maybe put a sulcus IOL instead. So this video can kind of teach you maybe skills or maneuvers for that case. It doesn't apply for this one where it's the lens is actually in the capsule, but something is rubbing the ciliary body and causing this UGG syndrome.
So now I'm trying to grab at that optic haptic junction and bring it under and just pull it out. And it's a little bit difficult from this angle. I just can't quite get under the haptic the way I want to.
Take your light pipe, pop it up.
Yeah, I feel like this is a skill that's actually hard, I think, to do at the beginning of fellowship, but using your light pipe to pop it up like really helps. But getting that angle, I think, it really takes actually some learning, and you have to be a little bit more aggressive than I think we're used to being as fellows.
Take the light pipe, pop it.
So, so what I ended up doing is I ended up putting a different paracentesis in, and I felt like I could get a little bit better angle from the other side. So we'll come and do that in a second.
At this point, I'm like yelling, "Don't drop the lens into the back."
That's what I was yelling the entire time he was cleaning the posterior capsule. I'm like, what is he doing?
These cases become so much harder if the lens drops back. You're like, if it's in position, keep it in position.
Mm-hmm.
I'm surprised you didn't pop it from the back. I would have done it at this point. I mean, I think at some point the manipulation's done, and then the second para, that if you have an attending or someone else helping you, can be. I like using the cyclodialysis spatula as on the side to kind of help elevate it. So if you have 4 hands on a case, that's how I like to do it.
You could also argue that you just, trying to dial it out might be better if there's already contact with the ciliary processes to avoid any, extra manipulation or trauma to the ciliary processes and bleeding.
It's already a traumatic surgery though. I mean, at this point, removing an IOL, taking the bag and such, as fine of a surgeon as you are, Dr.
This is like we're caressing the eye right now.
That's what it looks like to me. Looks like a gentle caress.
I think that brings up a good point. Like I always find I spend a lot of time counseling my IOL patients, probably more than even my RD patients, because I think people expect that it's going to be just like cataract surgery and their vision's going to be great afterwards. And I go into like great detail of, we're making like tons of wounds in the eye. We have to pull out this lens and sew them back into place, and it's going to be like, weeks before you're going to, sort of get that bump in vision. But I feel like sort of setting expectations for these people is good because it's totally unlike, their like first cataract surgery often.
Yeah, I was actually just saying that to Prithvi earlier today, that whenever I'm consenting my patients for any type of secondary IOL or lens exchange, I end up almost like talking myself out of doing the surgery. So I'm like, it's going to be terrible. And
you could have
like,
bleeding, you could have choroidals.
Yeah, exactly. I'm like, worst case scenario. And as I'm consenting them, I'm like, why would I even sign up for this surgery?
Yeah, and most of the times they end up great, but there's 1 or 2 people where they just have like long courses. It's hard.
Can I ask here, Charles, what you're seeing at this point? Because this looks like a pretty significant amount of cortical material or retained lens or a Summering's ring. So can you tell me a little bit how, like, what's going on at this point?
Sure. So our goal is really going to be to come with the forceps, grab the Summering's ring, and then try and cut it out with the cutter and use that grip to remove the zonules and bring it up. And you can see there's a significant amount here as I'm coming across, and even just like trying to grab it or cut it, you can realize that there's a lot that's going to come around. And what I'm going to do on the second side is I'm going to come in with the forceps and grab at the inferior temporal area and then try and cut it out. But exactly like, and some of it's coming, but it's coming kind of slowly. It can be a little bit difficult to cut for sure.
And then the other question I had during the case, this pupil is so widely dilated and this one piece IOL is sitting on top of the iris. But was there ever any concern that doing all this, leaving the lens where it is, it's going to fall back at any point?
Yeah, I mean, I was concerned. I don't know if you saw how long it took me to actually release the lens itself. I was like holding the haptic then I was holding with something else. We used MyCall to try and bring down the pupil a little bit. But yeah, definitely letting go of that haptic initially. There's kind of a moment of truth there. And I was worried. I felt like I had one haptic in and the other one, it looked like it was going in, but there was a lot of dilation. It was difficult to get it. So I was
there
worried.
thought,
Oh,
did
go
you
ahead.
guys think about, going in with a keratome and making not the full scleral tunnel, because this is a one piece, it's foldable, right? Making a small 2.7 and then taking out the IOL. It's a nice scleral tunnel, so you don't have the suture, it'll maintain a pressure, then going back and cleaning all this out, but at least you got the lens out. Because I feel like once it, again, falling to the back is like making this straightforward case now way more complicated and a headache and adding more time. And the cornea is just getting worse.
One of the other things you could do though is to, if you can get one haptic into the AC sitting on the iris, then odds are, it's probably not going to fall all the way back, though it could, or at least you have something to hold on to. So I think at some point, I can't see it. Like, I think we did have one haptic at least.
No, I think
sitting on the
here
iris.
it is.
Yeah.
That's why he's taking out the Sommer's ring and the rest of the capsule.
So I think I felt like there was enough stability with that there, that even if it started to tilt, you can go after, you'd have a handle to hold on to until you don't.
Okay, let's continue. There's so much to discuss.
And so exactly, so we're just pulling the rest of the capsule and trying to cut the zonules as we go across. And I was surprised at how much it seems like it's a pretty easy maneuver, but it's a little bit challenging actually grabbing it, getting a good hold of it, and then getting the cutter to cut the zonules was a little more challenging than I thought it might. Initially, I thought it was going to be. And here we come across to the other side, same thing. And then when I'm holding it, like I lose it and then I have to go back and grab it again. And I felt like I had a pretty strong grasp on it, but it still took a little more than I was expecting to be able to remove it. The nice thing is that the cutter is actually taking a lot of the Sommer's rings as well. So that's going, I'm happy with that.
So I would just remove it all. You're cutting the Sommer's ring off the lens.
Basically, I'm cutting the zonules. I'm going through and trying to cut the zonules.
Wow, just get the damn thing out of there. It's gonna fall back. Get the damn thing out, dude.
Never.
And then, so here we take the lens out. And then we put in the sheets glide, and then we're going to put in the ACIOL next.
Wow, good for you guys. Oh, even with the dilated pupil, you're not taking it down.
I think we did put myocol in. I don't think it came down as much as we wanted.
Yeah.
I love the sheets glide on these. I use it all the time. I think it's an extra level of protection. And if you do it really nicely, it gets it right into the angle on that first move so that you can rotate it nicely. So always check your white to white. Just make sure your white to white's checked before you even start. That's the one thing I always do.
Yeah.
And so speaking of that, how do you size these, Charles? So how do you decide when you measure the white to white, what are you looking for?
So yeah, so we measured the white to white. We had it with our biometry, but we remeasured again. And then you go up by maybe like 0.5 millimeter or a millimeter more. I use a table, one of the tables online. I think it's from like Hill RBF to size it. I think we're using a MTA3UO for this case, if I remember correctly. And so now, so now we're going to go and we're going to put in the PI, and we're going to put it in nasally. And so the lens is sitting vertically. We're going to put the PI nasally. Hopefully there's less visual effect in that nasal position, kind of like where we put a standard PI in.
And what are your settings? Oh,
so there we go. Yeah, this is my least favorite part of the surgery. So so yeah, my settings are too aggressive, and as I go on, as I put on, so it should have been like on a momentary or like a single cut setting, and I go in and it's much faster than expected. And so now we have like this, we've sort of created this defect in the iris. And I was surprised, I wasn't expecting that, but I haven't, this is one of my first PIs that I've done.
Yeah, I think the PI can be a stressful part of these cases. And I find that, most of the fellows like don't want to be that peripheral. So you end up being more central than you should be. And I think it's the end of the case, people are tired, and I think it's just a little hard to know sort of where you are. I like momentary for these, and I like to aspirate and sort of hope to see some of the iris get pulled in before I commit to sort of cutting for my PI, but it's definitely something that takes a little learning.
I like coming anterior for these because otherwise my blood pressure is way too high when the fellow's doing it from posterior and you have no idea where the tip is. So I like coming right into the AC. And I think it's so much safer, pointed down, momentary, single cut, and that's the safest way to do it, I think.
But yeah, I turn the cut rate down low, and then I actually go on to vacuum, and I see the iris dimple into the cutter's mouth, and then I just push the pedal down once, chomps, and then we're done.
I think also it's just like if you're scleral depressing and you see the shaft. Like I think your technique is great, Carolyn, to be able to see the tip. I think sometimes though you can be fooled as to where you're actually at, and you're kind of pushing up on it. And you think you see the indentation of the cutter from behind, but actually aspirating as you can see it kind of coming into your port is really important. And I think like when you're trying to get inferior PIs to keep your oil out, it's important to get as far peripheral as you can, but you don't want to get so peripheral that you're eating the ciliary processes.
So at this point, we evaluate after this, and we're happy with how the lens is sitting. The lens looks like it hasn't been destabilized. We have a larger iris defect than we want, but at this point, we decided that we're going to close up the case. We're pretty happy with the overall result. We're not happy with the iris, of course. And then we'll see if the patient has photopsias at that point. And so we close up.
The wound was pretty
Awesome, Charles.
watertight. It was well done.
It's very brave to show the oopsies.
Well,
we had a chat about whether we should try to at that moment, should we try to fix the iris defect or suture the iris, and I think at this point everything was okay, and there was going to be no pupillary block, and the lens was stable. It was still resting on the iris, so live to fight another day.
I think most people do just fine. I mean, I think that I look at some of my not so great looking PIs. And I think it bothers me more than the patient, or they're only become aware of it if you bring it up to them. I think the chances of having symptoms are sort of lower than we would sort of think or expect.
Yeah, I think for this case, the lens is stable. So again, it's like part of the surgery is knowing when to stop.
Right. Yeah, I think it's a good point. We were happy with the stability of the lens, and we thought the patient was going to do well. The patient was seen post-op month 1, vision 2300, pinholes to 2070. The patient had a lot of corneal astigmatism to begin with, over 2 diopters. So I think that the vision is going to be pretty good once we correct the astigmatism with glasses. There's a nasal iris defect, but the patient hasn't had any issues with it as of now. There was a little bit of mixed cell and pigment, but all in all, things were looking pretty good post-operative month 1. So we're pretty happy with the result, all in all. I think we hit a lot of our questions and considerations for the case. And I had just put a couple slides. We didn't put a lot of ACIOLs in as a resident. There's kind of a bias against it. And I just put a couple slides showing that ACIOLs, they do 3-year studies versus 1 year for posterior chamber. They have a grid like every other lens where they have like an acceptable number of complications for them, and they have rates that they need for better than 20/40 vision. So they're regulated. It's a very well regulated field. We had looked at like whether or not scleral fixated was going to give us a better visual acuity, a better result than anterior chamber IOLs. And there's been a few studies showing, this study was earliest, the lenses was in 2007. They had a better visual acuity with the anterior chamber IOLs, but in a follow-up study, it was comparable. And the complications, what they noticed in this later study was that, there's earlier transient complications with the anterior chamber IOLs, with transient corneal edema, But the late complications are similar, and the visual acuity is more correlated to the late complications. So in terms of results, they can be very similar between the two technologies or two techniques. All right, I want to thank everyone who's helped with this case and who's helped with this patient.
Great case, Charles. Thank you, Carolyn. Nice job there. Great questions in the chat. Prithvi, I don't know what you really did during that case, so I'm not going to compliment you. My pleasure to introduce one of my partners, Kat Talcott. Kat has been with us for several years here at Cole, did her fellowship at Wills and residency at Mount Sinai. And Kat's going to run this next case with Jess Cow. Take it away, Kat.
Awesome. Thank you so much. I'm so happy that Jess is going to be presenting one of the cases. She is one of our awesome second-year fellows. She did her medical school at USC, and then she came to Cleveland for Colt for residency and stayed on for her fellowship. Loving the image already. And I'm excited to say that she recently signed, and she's going to be joining a private practice in LA close to her home. So I'm so excited for her. Jess, do you mind sort of starting your case?
Yes. Okay. Thanks for the introduction, Kat. So I think maybe a couple of faculty members have seen this video, so I apologize in advance for the PTSD and reliving this moment. But this is a video that I did with Dr. Alex Ewan, who I don't think is on this call, but bless his soul for his patience during this case. So he's with us in spirit here. So this is a case of an MX60. This is an 82-year-old Caucasian man. He was referred for retained lens fragment after complicated cataract surgery. He has a history of, and this is in the left eye. He has a history of cataract surgery in the right eye. It was uncomplicated. He had a full thickness MAC hole surgery in his left eye that reportedly failed back in 2013, done in an outside hospital. A comprehensive cornea specialist saw the patient in August over at Cole and called it a lamellar hole. Here's the OCT. I think we can agree it's a full thickness MAC hole. The patient then saw a different comprehensive provider at Cole who opted to do cataract surgery, and that led to, unfortunately, a posterior capsule rupture and then a retained lens fragment. And so the patient was then sent to us. This patient had a vision of hand motion, had pretty significant corneal edema when we were seeing them, and they were left aphakic. The view was hazy to the back because of the cornea, but a B scan did not reveal a tear or an RD. So,
hey, Jess. So just to jump in, sorry, go ahead.
I guess the question that kind of looms in everyone's mind is, why did we even decide with this chronic full thickness MAC hole to do this surgery to begin with? I don't know if that's where you were going with this, Dr. Talcott.
I'm going to actually ask something else, but you can go ahead and lead with that one.
Yeah, so I think that's the question that was on my mind when, I saw that this case was posted on the board. Not that I was going to complain that, I was going to get to do this case, but I think that was still I think a question on my mind, like, why are we even doing this? Like, I can understand the reasoning for obviously going in, doing the vitrectomy, removing the lens fragments, but why not leave this patient aphakic to begin with? And I think the reasoning was, well, it was one of our own cataract surgeons who decided to go in, remove the cataract, and put a lens in. That was the plan at the time, per the discussion with the patient and the comprehensivist. So I think it would have been, I think it's a little bit of a sticky situation when the person that referred you to them had told the patient, I'm going to put a lens in. And if you end up, removing those fragments and then leave the patient aphakic, I guess the question is, well, why did my cataract surgeon want to put a lens in to begin with? And I think that's
yeah, Jess, I think that's a really good point. And I feel like the sutured lenses, at least for me as like a retina surgeon, I think your relationship with who refers the patients to you, I think, is a little bit more delicate than they are for most of the other types of cases that we do. You have to think about sort of practice patterns. And I think there's that dynamic. I think the other thing, though, is, even if there's like a full thickness macular hole, like the patient might be eccentric, like fixating eccentrically, might have, probably has better vision than sort of hand motion. And I think, you know, putting a lens in position can help with peripheral vision too, to help the patient sort of use both eyes together. So I think there's, you know, I think there's valid reasons beyond just sort of surgical numbers in next cases for fellows too. I don't know if that sort of factored into Alex's mind as he signed.
Was there any discussion about staging it?
Yeah,
Just
so
taking
that
out the
was-
lens fragments, letting him or her heal, doing refraction, maybe even trying a contact lens to temporarily see if the patient notices any difference, and then going back in.
Yeah, so I think that that was one consideration as well. I think that another consideration was since this patient had a chronic full thickness hole, there was a plan to go back in to fix that hole. So we could have just removed the lens fragment now and then later on gone in to do both the sutured lens as well as fixing that hole. I think ultimately when they had a discussion, the patient was like, let's just take care of the lens part now, we can figure out the MAC hole part later. But there was a discussion in terms of how to stage it and in what like which steps to do now versus later, but definitely all considerations.
I think that's a good point. The other question that sort of I had as you're pulling up this slide is, I think that there's a lot of variation about when people take these patients to the OR. It sounds like there was a fair amount of corneal edema at this point. I was just sort of wondering, like, maybe Prithvi or Sunil could sort of jump in about like, what's your sort of optimal timing for going in these cases, and sort of what do you try and do to sort of optimize patients before taking them to the OR?
Yeah, so I was worried about the corneal edema as well, because something that's straightforward can get really messy if you can't see into the back. So making sure that pressure is under control. I don't, if the pressure is good, I don't think that, and the inflammation can be controlled. I don't think there's a really big emergency to go in, especially if you think it's going to be harder than anticipated. So I would like that cornea as detergest as possible. Like, I'll hit them heavy with steroid. And then you also realize that you might need to scrape to get a view and detergest however you can. But I think that cornea always worries me a little bit.
Yeah, I think that's a really good point. I don't know, I've often felt pressure from some of the cataract surgeons in these situations to do the case like right away, and they often, and sometimes they'll tell the patient like, you're going to have surgery like tomorrow. And then you see the patient, you're like, this is going to help no one if we go back right away. So sometimes it's just getting patient buy-in that it's going to be better to wait, safer for everyone. I think it's an important sort of point to bring up as you're seeing the patient and talking to the cataract surgeon.
So the other way to take this, and again, practice pattern, is that I think, when this type of patient comes to me, like, you just have to own that patient, fully. And it's almost like, the decision making not to put a lens in, even though your awesome cataract surgeon really thought it's the right idea, in my hands right now, I think we should do it this way, and then we'll consult with your surgeon and make sure we have the right lens, and kind of wiffle waffle a little bit, because being forced to deliver on something that at the end of the day, if this cornea is crappy and endothelium sucks, and you start rubbing against it, and then the next thing you're doing like an endothelial procedure, that's on you. It's not on the first surgery. So sometimes just kind of owning it and deflecting and still making your referring doc like awesome for having sent it. What a great plan that they sent you right over. I don't know. It's like, it's a little bit of little showmanship. I don't know.
We also, I think, not infrequently, and I think it depends on the provider. Sometimes the comprehensivist or the cataract surgeon will know that we're in the OR next door and will ask us if we can bring this patient in and do the surgery the same day. I think it becomes kind of a difficult situation if the patient received anesthesia, and how do you end up having that discussion with them, and how do you consent them? Does anyone ever routinely take those patients the same day? And like, what's the timing? Because I've seen it happen maybe just a couple of times, but I guess I wonder how commonplace that is.
In our OR setting, when it's like right next door and we can do it, we do, right? So when it happens dynamically, and the retina surgeon in our institution, retina surgeons next door to the cataract surgeon, sometimes we'll just take the cataract surgeon patient out and then bring him into the retina room after our case. So I don't think necessarily, unless there's an true emergency or it's convenient to do that. I think staging, and Prithvi, I believe, wrote a paper on this a while ago that I like to cite that actually shows that the outcomes are pretty similar.
Okay, I'll start with my video since it's
But if you're
kind of long,
asking
so I
about
might
medical
stumble.
legally, Jess, I think medical legally, if you have two physicians that agree that an emergent procedure is necessary when the patient can't give consent, you're allowed to proceed with it. So you just need to make sure both you and the cataract surgeon document that it would needed to be done emergently and consent could not be obtained. And that both agreed that it was the right call and the safest option for the patient.
Okay.
All right, let's get to your video, Jess.
Yeah, so sorry, just as I was saying, this video is a little bit long, so I might skip forward for the sake of time. So we start off with the parotomy. I think most people over at Cole do their IOLs at 3 and 9, so on the horizontal meridian. So we made that with a horizontal axis marker, and then parotomies nasally and temporally, a little bit of light cautery. Alex uses the trocar markers to help measure because he does 3 millimeters back and then 4 millimeters apart. And so that is a convenient way for him to just measure that. So we start off with that. I'll skip forward. We do the vitrectomy. It's a 25 gauge, obviously. And then we remove some fragments. It is actually a pretty dense lens. It was kind of a brunescent 4+ NS. So we obviously shave peripherally, check for any breaks and everything. But there's one piece left behind that we're not able to get with the cutter. So make a para, inject a little bit of viscoelastic. I think that was actually Provisc. Make my wound. And then we ended up using max grip forceps to retrieve the piece from the back of the eye.
Are you guys trying to sort of get away without using the frag by just grabbing that piece?
Yeah, exactly. So because we had our main wound, what we're doing here is I think Alex is kind of helping a little bit with the light. And then we used McPherson's to kind of burp it out of the wound here, and it came out nicely, fortunately.
Oh, nice. Gone.
Very slick.
Beautiful.
Yeah, so for the real fun.
And as you're doing this, can you just briefly tell us about why you decided to do an MX60 for this case?
Yeah, so I think that we could have honestly gone both ways, but because I think the patient, we thought about the MAC hole and kind of what the patient might require in the future and the worry for opacification with gas, we decided to go with the MX60. I think that was the main concern.
Mm-hmm. That makes sense. It keeps your options open for later. I mean, the risk is like super low with AO60, but
Yeah.
you know, if there is a risk and you can still do the MX60, then I think that makes a lot of sense. I can see why you and Alex decided to do that.
So this part's relatively uneventful. We decided to loop the Gore-Tex suture on one side first before putting the other Gore-Tex through on the other side. I will honestly say that my least favorite part of putting these MX60s in is keeping this Gore-Tex suture above the haptic in the right position.
Yeah, I mean, it's definitely trickier than doing an AO60. I sort of find I just always have to do things in exactly the same order. And I really rely on sort of the visual cues that I get from doing, things in exactly the same way, each case. But you have to be pretty OCD about sort of doing things in a way that you feel comfortable with to make sure that those sutures stay above the haptic.
Jess, can you tell us what you mean by keeping the sutures above the haptic? Can you show us on the video? Because I don't think everyone knows that.
So for the, I guess those who aren't familiar with the Invista, you loop, I think it might be easier to see maybe on this side. So you loop the Gore-Tex suture from top to bottom through this eyelet, and then it comes out through the bottom, and then this should go above the haptic. So as you can see here it's easier to see on this side. I don't know if you guys can see my cursor. I don't know why. Can
Yeah.
you see my cursor?
Yeah,
Okay.
looks great, Jess. Thank you.
Sorry. So you loop it from top to bottom, and then as it comes through on the other side, it should remain over the haptic, if that makes sense.
And I have the same question that Eddie asked in the chat: is who cuts the
Oh.
haptics and who leaves them?
Oh,
I
that's
definitely leave
interesting.
them. I don't know. I guess, I mean, I don't really quite get how you benefit from sort of cutting them off. I because I haven't had any problems with keeping them there. So I don't really understand why
So-
cutting them off would be
I'm
beneficial.
sorry, that keeps happening. So what I'm trying to do here is keep this haptic tucked under. It's not quite working out well for me, but I think that would have helped us kind of immensely in trying to keep the Gore-Tex where it's supposed to be, and similarly for the opposite side
Yes.
here. So I did neither side when I should have. I'm double checking things here as I'm putting it in. My attending is kind enough to pull this side, but as you can kind of see here, it's loose on one of these Gore-Tex sutures, so it doesn't end up actually slipping through. So that Gore-Tex suture ends up getting caught on the trailing haptic. So here's
Yeah,
spaghetti number
I think
one.
one of the keys for these cases is just keeping, as you're dunking it down, you have to have like really good traction
Right.
on those sutures. Otherwise, you can just get lost.
And here's problem number one. You can see that this Gore-Tex suture has unfortunately lassoed itself on the trailing haptic. And so we're taking a moment to kind of figure out what's happening here.
Just pull a little straighten, actually. Just give it a little tug. Tug and a flip.
And then another question I had was: are people moving away from using this lens with the eyelet fractures, or are people still using them? Anybody in the
I'm
audience
still
wanna weigh
using
in?
them. I actually do them. I mean, we did a lot of them during fellowship, and so I'm still doing them. I definitely understand why there's eyelid fractures. I mean, I think our tendency is to sort of tie the sutures tight, and that can rip through that eyelet. And the lens is a different material than it was like 2 or 3 years ago. But I think if you're conscientious about keeping it sort of looser and not really tugging down on things, then I haven't had any sort of eyelid fractures. And I suspect that that's where they come from. But there was that nice presentation at ASRS on the incident of eyelid fractures. And I'm not sure if anyone else has decided to step away from them because of that.
So I want to just show how this other side ends up being. Sorry, guys, I'm terrible at this. I keep trying to hit the pause button, but for some reason it's advancing instead of actually hitting the pause button. So maybe I should just not pause it. So you can kind of see here that the Gore-Tex suture actually ends up underneath the haptic instead of over it on this side. It's fine on this side, but this side ends up actually underneath. So it's supposed to be over the haptic now.
Pop it over.
The hard thing with these lenses is sort of once you get it sort of lassoed or hooped around somewhere, to try and sort of undo it is really challenging. I've found that when I get in this situation, I just think it's easier to just take the lens out and start again, because otherwise the lens can sort of rotate and it's hard for sometimes you to recognize that it's rotated.
Yeah, so I think that, that probably should have been step number one for us. And instead we tried every other method before trying that, because why not? So, we tried to do it from the inside. I think it was partially my fault because at this point as a second year, Alex is now asking me, what do you want to try, Jess? And then at the end then says, I actually would have tried just taking it out of the eye first. And I was like, that probably would have been a smarter move and good thing to do. But I really appreciate him, asking me for
Oh no,
like what.
No.
And that's part of the process though, right? And then when you're in practice in 6 months, when you're in the situation, you're going to remember, it's going to be burned in your mind,
it's
the time you
seared in
spent
my
trying
mind
to do it.
Right. It's now seared in my mind, and Alex likes to remind me of this case.
Just pull to the
I'm a little bit traumatized by it. So, we tried to loop it from the inside. It didn't work. We decided to take it out altogether and then try to re-loop it again from the inside, which was my next suggestion, which again was wrong number 2.
Tough.
So he's watching me struggle with this. It was
Alex
not
is the most
a
patient man
fun
ever.
time. he's pointing out like what I should do, and he's like, well, if you want to try that, we can give that a try. And then in the end, he's just like, why don't we just try taking the haptic out? I'm like, oh yeah, we should just try taking the haptic out. Let's do that. So that's our next step.
Should we thread it?
And I'm sorry, I'm just kind of rolling along here. I'm kind of scared to pause this video again.
You're doing great, Jess.
For some reason, every time I hit pause, it advances. I apologize. So again, just to show you guys what Dr. Sharma was asking me earlier, you go from up to down, and then this Gore-Tex, it should be above the haptic. And so I tried looping it again from the outside. I dunked the lens. It's tilting, which is not helping either Alex or I with our anxiety levels at this point. And we're really testing Alex's patience here. Flipping over again. And here's when I really start thinking, we really should have just taken this whole lens out of the eye and started over.
I think this case is really illustrative though, because like when you go to conferences, people present these like super slick videos of IOLs, you know? And then I think like in reality, I'm sure all of us have had an encounter like this where you just sort of really struggle with it. And then you're like, you know, ACIOLs are not a bad option.
But what 100% when you have this next case that you're going to do, like you will have this down because you've been through this now. So, you know, your checks and rechecks will make a lot more sense.
True.
I've kind of gone away from the Invista lenses lately because of this. And I did have one case of an eyelid fracture. And you just don't get this issue with the AO60. I mean, you can put it in completely wrong as long as you push it way back and tighten the sutures. It flips itself, it rotates. I mean, it's pretty easy compared to this. And I think I just had a lot of times that I had to struggle a little bit with these things looping over the haptics in the wrong way. And it just seemed like it was kind of a pain. So I kind of went away from using this lens unless there's a good reason, like they're having a dissect likely, or some reason that you think, you know, you don't want to do a hydrophilic lens.
All right, so what we ended up doing was, hopefully you guys saw that as the video was rolling, I made a second paracentesis. I injected some more viscoelastic, stuck a cyclodialysis spatula in through the opposite end, folded the lens in half, and pretty much extruded that MX60 through the main wound. I'm rechecking those sutures, making sure again that they're in the correct position.
Looks good.
I decided.
You got it.
I was a little bit unkind to the iris. I think it extruded a little bit, so we injected a little more viscoelastic to reposit it. I refolded the MX60 lens back into its place, made sure the Gore-Tex suture was correct, made sure that, again, on this side, we had a nice taut hold, unlike the first time around, just to make sure it doesn't move on us and lasso again. I'm sorry, David Greenman, do you mind muting yourself?
Oh, I'm so sorry. Oops.
Thank you so much. And then here I am dunking the lens again, making sure that it's in the right position. I'm not letting that trailing optic out of my sight. So I'm this second
You've
time
learned your
around.
lesson. It is
I've
burned
learned
in
my
your mind
lesson,
forever.
right, exactly. Lesson number one, just take the whole thing out. It was so much easier. It took us much less time to do this than to struggle through the first parts, but I do appreciate kind of having the opportunity to try those other two techniques and those two options and realizing that they are not options. And
thank you so much for showing this case, Jess. I feel like, you know, we've all been
it was
here.
a struggle.
It's nice to actually sort of see, and I think there's a lot of sort of teaching points for the other people watching.
Not
I also
my
feel
point.
like a really bad attending because I'm not as patient as Alex. At this point, I'd be like, no more lens, aphakic, close the eye, we'll come back another day.
No one is as patient as that.
Jess, I mean, this is a great save at this point.
Yeah.
Can you tell us how did you figure out how much tension to put on that? I think that's always a hard one, right? Like you could put one side too tight and moves the lens. Like, are you planning to go in and look with an iris push pull or something to kind of, you know, see the centration? Like, how do you know how much tension to put in when you're doing this now?
Right. So I don't know that if I display it in this video, but routinely what I'll do for the lenses is I will tie down both sides and then I will check with, I will tie down both sides and make sure that there's not too much, it's not too loose and not too tight. And I'll try to even it out. If it's too tight on one side, then I'll loosen it and then retighten the other side to just bring it back into centration. And then before I tie it down, we do 3-1-1. Some attendings here will do 3-1-1-1. Before I tie down the one after the 3, I'll take like a Kugeln hook or a Sinsky. My preferred is a Kugeln hook, and then just sweeping, pushing the iris back and just making sure it's well centered with the patient's visual axis. And then when I'm satisfied, then I'll go ahead and tie one on one side. And then because that can, when you tie down one on one side, it can tighten that side and theoretically pull the lens a little bit towards that side, which is what I found. I'll go ahead, instead of tying another one on that side, I'll try to even out by going to the other side and tying down one, and then I'll alternate back and forth just to make sure it remains quite even.
And then any
Peter
tips?
and Vineet are mentioning slip knots instead of tying a tight 3. Then you might have a better chance to adjust. I think that's a good idea.
Yeah.
What about any
absolutely.
tips to avoid what Kat had mentioned, like the reason why she thinks there's eyelid fractures, people just like cinching it down too tight? Do you
Yeah.
put like a little cyclodialysis spatula or some instrument to have so you can like tighten against, so you're not as tight, but you're not actually choking the sclera?
We don't routinely do that, but that's definitely a great suggestion. I definitely want to try that next time, but I haven't seen an attending here do that yet.
I think that's a good idea. I just find myself just always telling the fellows, like, you're going to try and make this tight, try and make it as loose as you can, and then trying to like loosen it. And you'll see with the MX60, if you tie it too tight, it starts to torque a little bit. But I think everyone's inclination is they don't want that not to go anywhere. So they just want to make it as tight as possible. But you can still make it tight and have have there be a little bit more laxity sort of on the lens itself. But it's a hard balance. And I think no matter what we do, it's always going to be a little tighter than what we want.
Okay, I don't think the last part of this video is exciting or anything, so I'll move on. So the patient's about 3 months out now, still, of course, has some corneal edema, not quite as much as, of course, when he started out. He's currently on mirror drops and seeing us alternating with his comprehensivist who originally did his cataract surgery. Right now, his vision is limited by the chronic full thickness back hole, and I think the plan is to get his cornea in check a little bit and wait until things kind of calm down before we proceed with the next stage in his surgical plan, which is addressing the hole. And with that, thank you all for your input.
Thank you so much, Jess. I think that was a great case and we learned a lot from it. So thanks so much for showing a challenging case that didn't go as smoothly as I'm sure you had hoped.
Lens was in place at the end. That's all that matters.
Yes.
Carolyn, you want to take the next one?
Yeah. So next up is one of our second year fellows, Eddie Karat. Eddie, recently, we just celebrated him last week. He's one of the Ron Michael Fellowship Award winners, and we're really sad to see him go at the end of this year. Final destination TBD, but he's a skilled surgeon and really excited for him to share his next case. Take it away, Eddie.
Awesome. Thank you, Dr. Pan. I'm going to try to hit optimize for video. Hopefully this will work. Okay. Okay, so Cobra rounds, December 20. Actually, I saw this picture. I don't know if you guys knew this, but this is totally unrelated. But Cobras have this, like when they shed, they have this eye cap and it needs to be pulled off sometimes. So random bit of knowledge.
You put
I
a
feel like now I'm going to have a nightmare of a
MX60
Cobra.
Do you put an MX60 on top afterwards, or do you have to suture it in? Or
Touche.
I prefer an Acreus. So this is a 53-year-old male presented with decreased vision, left eye for 5 days, extensive past ocular history of bilateral panuveitis. So he was under the management of our uveitis team. He also had cardiac sarcoidosis. He was still dealing with some macular edema in the left eye. His meds had been changed. He'd been on Humira, but he just switched to Remicade for some better control. I believe he had some residual leakage at the nerve at this last appointment. He's also on methotrexate sub-Q and has a past surgical history of
a vitrectomy with IOL exchange 1 year ago. So his presenting vision was 20/70 in the left eye. Here's a picture. You can see the inferior retina is detached, extending halfway through the macula about. So you may be wondering, why is there an RD if we're talking about lenses? You shall find out. Here's an OCT through the macula showing shallow subretinal fluid. So let's get going. So the plan was to do a buccal vit for this patient. So I spent a little bit here on this video showing the peritomy. And the peritomy was a little bit unusual. It was kind of tight in that area around 9 o'clock right there. I didn't know why initially. So just trying to dissect around it first. Made my way around the superior side pretty easily. And then again, it's tight there around the 3 o'clock area. Also didn't really understand why. So making it around and then just trying to dissect a little bit further. There's kind of a focal area of congentinon's adhesion to sclera over there. So kind of leaving it alone for a little bit, spreading in the quadrants for the buccal. And then that area is still kind of tight. So decide to just kind of cut it off. Kind of like a focal granuloma, if you will.
Well, he's
So-
previously vitrectomized, and that's infratemporal.
Yeah.
Or is that so? Like
No,
the
that's
infusion.
nasal. I think.
Oh,
that-
infranasal. Okay, never mind. I was trying to throw you a bone here.
Doing the buckle here. The tending I was with likes to do belt loops. So we're aiming for as deep as we can without going too deep here. 4 millimeters by 2 or so, and 4 millimeters back.
So just a quick straw man poll of the faculty: who does spout loops and who does sutures for their combo buckle bits?
Sutures.
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 Same. Although watching this video, I want to try belt loops now.
Well,
I did
one
like
quadrant,
two in fellowship. Yeah, they look awesome when they work.
It's like a Bascom thing. So all the Bascom trained people here do belt loops, and then everybody else uses suture. And I like held out just on principle, but I don't know. I'm swayed
one
a
was
little bit.
a bit too thin, or
Oh, it's
a
thin.
bit too thin. Yeah. So like
Yeah, it looks a little
parts.
wimpy.
Make me
That's better.
nervous.
And then for those who suture, just in the chat, who uses Merceline and who uses nylon?
If I'm feeling really nice to the fellow, Merceline. If I want to make a
Nylon.
point, nylon.
That one was a little bit deep, so I was careful to not push too posterior in that quadrant when putting the buckle around. Kind of, you'll see on that last quadrant, was careful to lift up a little bit right here and really angle the, yeah, anterior there. It did seem a little bit like that one was deep.
But not too
Oh.
deep, right? Just
It looked a little bit deep. So then put in the ports. I'm going to find the break. So that, although small, we couldn't find any other breaks other than that one super
And then
temporal
also,
there.
he's been vitrectomized before. Like I was impressed by that was like quite a bit of vitreous left.
Yeah. So yeah, so there's no hyaloid face there. So just cleaning around the break. And then starting to go into shave. There's kind of some more thin retina out there. Some pigmented spots. We didn't think those were full thickness. So kind of a
Good question,
posteriorly
Peter.
inserting vitreous base. Sorry?
Peter asked, "It was this patient vitrectomized previous at Stanford or outside?" And I said, "Good
I think
question."
it's Stanford. So then when we switched back, you can see that something's happened. The acroleus lens that I didn't know the patient had is now half dislocated posteriorly. You can see the eyelets there.
No.
So, so I'm going to ask the faculty, what would you do at this point?
Yeah, I think the question is more, do you try to fix this first and then get back to the RD, or do you deal with the RD and like deal with your view and then worry about this lens after?
If you
I
can't,
feel like, go ahead.
no. Go ahead, Steven. Yeah.
I would put in, oh, sorry. I would wait till I had the perfluorocarbon in and the retina was stabilized, and then I'd try to resuture.
So
Right.
you would for sure use perfluorocarbon in this case. That's like another question is who uses
That
PFO
haptic in
and
the
who would,
eye.
because the causative break is supratemporal and all the fluid is like inferior, and then the causative break is actually flat on the buccal. So if you put PFO in, like a lot of the fluid, I think
Yeah,
it gets sequestered.
I would want my retina. I would definitely use PFO and get the retina attached mostly, and then deal with the lens. And once the lens is all fixed, then I would do the air fluid exchange and take the PFO out.
So you're
Danielle,
using
what would you
PFO
do?
really for stability, right, Steve? You just want things stable at this point, retina as flat as it can be, and then, but you're not.
Yeah.
Yeah.
Yeah, I if you're going to try to resuture within the eye, the lens is going to be moving around. You don't want the retina moving around. I just think it'd be nice to have that PFO there. You may not want to do a full PFO fill because that might actually push the lens into a position that's not easy to work with. But I think just having at least the retina stable to a certain extent would be nice when you're trying to do that.
I agree
I
from the
agree.
stability side.
I agree with that. And I think a couple things, you're going to be manipulating more anteriorly. If your retina is bullously detached and you can't see it, you're going to probably cause something to happen with your manipulation. So PFO to stabilize things, maybe get rid of some of the subretinal fluid. You can do fluid, but it's going to reform. Allow you to float the lens a little bit if you wanted to. You can always take PFO out. You can add a little bit more. So, and I agree, you have to deal with the IOL first before you do air fluid. So I would do it now because you have a good view. So just go mark your breaks though. I love what I would do that. I would make sure I knew where every break was and mark them before adjusting the IOL. So just so if my cornea goes and I lose a little bit of my view, I at least know where I can laser and such. So that's what I would
The
do.
PFO crew though, I don't think the second half of my question was the causative break is supratemporal and it's like flat on the buccal. If you put PFO in, wouldn't you just be pushing more subretinal fluid anteriorly, which is where you're manipulating? Or do you think it'll like move around the buccal and out that break?
Yeah, I think it tends to move. I think if you orient
It'll
it and
squeegee
push it
out.
around. Yeah, I think so. I've never, and if you give it enough time, right? And if you're high anterior, let's say for a bit, that high anterior fluid, if you're over the break, will squeeze you towards, or at least move towards the causative break. So yeah, that wouldn't preclude me from using it.
Sunil, I love your comment about diathermizing the brakes and making, because that is so important. I think, there's certainly been cases where I didn't remember to diathermize the brakes before something happened, and then you can't see them, and it's really, so that's a really good comment and really important, I think.
Yeah, and I think you make a decision here, about the IOL, right? So you make a decision of the most important thing is reattach this retina, right? The IOL is bonus. So I would say if I can do this easily and get this to position, awesome. If I can't, take the lens out, fix the retina, come back later. That's what I would do.
Well, thanks, faculty. Now we know why this is a lens case and what started as an RD. So you can kind of see actually the cortex suture. So we decided to kind of go for the retina first. That was the primary reason we were there, and our view was okay. And so we're just getting some residual peripheral vitreous. And then we put in a chandelier. Here we can see where we're manipulating the lens with the infusion. So now we're marking, we actually decided to go with the drainage retinotomy and not PFO, just to try to fluid, get the retina a little bit out of the way here. And it seemed to flatten okay. So we decided to laser right there. So now we decided to put another port because those weren't quite the correct distance back, and to do a hand over hand technique and take care of the lens. And so I put the Gore-Tex in with the max grip on the one side through the port, and then the goal was to loop it. It was to go with anterior view because it was kind of anterior at this point, to try to go straight through the eyelet with that hand and then grab it on the other side. And the bubbles, I probably should have cleaned those out first. So we passed it along to the other hand, and now we're going through the sclerotomy that we created that was additional, and to try to pass it through. So to then go with that hand and through the eyelet, and then pass it off. So couldn't really do it from an anterior view there, and then posteriorly, of course, the bubbles are in the way. So while holding that for dear life, take out the bubbles and try again. And actually now it was kind of visible here. So just went straight through the eyelet and grabbed it and pulled it. And then
You know, Eddie, if you would pause for a second, that's one of the reasons I love the actors a little bit, is you can manipulate, you can get your forceps tips like right through that eyelid. It's actually relatively forgiving. So I've done that, you know, it's happened to me before, like something like this. And I'm always impressed. And the Gore-Tex is nice because it kind of can lay in a certain position. So you can kind of quickly pass it to yourself without having to actually physically pass it to yourself. So nice job. That was great.
thanks. Yeah. So some fluid reaccumulated because we're just fluid. So now we're going to air and just lasering some more.
Eddie, Peter's asking, what happened? Did you guys check the sutures on the other side? So they
No,
didn't
we
snap on
didn't.
the other side?
No, we actually didn't check. So it seemed to be pretty stable. But yeah, that's a good thought, since I was dissecting there for the peritomy, and that's what ended up breaking the suture on the one side. It would have been a great idea to check the other side. So here, just trying to center it and not pull too tight. And as you can see, we have air in the front of the eye as well. And then we just finish the buckle and close the peritomy. And so that was the case.
So many teaching points here, Eddie, but what's the number one teaching point?
So I'll get to it on this next page. So the vision post-op week 1, this was just the last week. So this is all I have is count fingers at 2 feet. The retina is flat and there's no pseudophacogenesis. So the number one teaching point is the preoperative documentation and chart review. So I'd reviewed the charts of this patient, and it was a complicated uveitis patient, and our uveitis patients tend to have 10 to 20 page notes, very detailed. And I had reviewed those, but there was nowhere in that note where it was documented that the patient had a sclerofixated IOL. Now, if I went back and actually read the op note from the lens exchange, I would have obviously known that, because that was documented there. And that just taught me that I can never trust looking at one recent note, even as extensive as our uveitis service makes them. And so definitely taught me a big lesson there. Really know your patient and really look at all the documentation that you can. And so we kind of already talked about the operative decision-making, explant. I guess we didn't talk about just leaving them aphakic if we couldn't get the lens fixated. versus exchange versus the rescue that we did. We did talk about when in the case to fix the lens, and then maybe we can talk a little bit about opacification concerns. And I have some papers on the following slides about opacification, especially because we had gas, or we had air and then gas in the front of the eye and in the back with the AO60.
Yeah, so I think the rescuing, but then if the rescue was super complicated, like the last case, I would have just explanted and left the patient aphakic. I would not have exchanged again when you're dealing with an RD. So that, I think that point we already discussed during your surgery, and we can just like also leave that. But I think the opacification is something that we can discuss with the faculty who are on right now.
I had a question regarding, you know, people had said, did you check the other suture? You know, how would you have checked the other suture? What would you have done, you know, like to check it?
I think, yeah, it's easier said than done. That's a good point, because it seems like these Gore-Tex sutures kind of get ingrained into the tissue, and, you know, they're porous, so that's what they're meant to do. And they can form focal granulomas there as well. And so I wouldn't want to necessarily dissect further there to check, with the fear that I could possibly do the same thing on the other side that I did on the other side. So I don't know if really necessarily we would check like visually, but maybe if we're brave enough, we could try kind of pulling on the lens a little bit to check the integrity, like we do sometimes with scleral passes for buckles. I don't know what anyone's thoughts are on that.
Peter Tang is suggesting we try to forcibly dislocate that other side that was fixed.
Yeah.
You know,
Just
I would have,
because the case wasn't long enough.
I would have probably just put a, you know, with your para, I would have done kind of what Pierce kind of mentioned. I would have probably taken a Kugelin and just pushed the iris and just looked at the other side.
Yeah.
You know, just to kind of see it. Let me ask you this though. So, you know, you're giving yourself a hard time, and you should get a hard time for looking at the chart beforehand. Let's say you knew it was a suture, an acreose. What would you have done differently when you've opened?
So I would have avoided that area.
Well, you're going to have to open that area regardless, right? I mean, you're doing a 360, right? You're putting a buckle on. So how would you have changed your opening? So I think this is the question, because we all are going to see these patients. Patients are going to detach. So how do you open in this kind of case?
Yeah, I mean, I think
you may not know the
initially,
answer, and I think I'd love to hear what the faculty thinks. Like, what do you do differently?
I think initially I would try, and then if it was sticky there, then I wouldn't really push it, and I'd just open around it and not necessarily open to the limbus there. I don't know if that's reasonable.
I think Peter and Adrian have some nice comments that you might consider not doing a buckle in that case. You might consider just trying to get away with a vit and doing a longer acting gas, which is not a bad idea. I think it's kind of interesting, right? I think it's going to be a problem that we're going to encounter a lot more as the year goes on, as the years go on, where it's more common for people to have these Gore-Tex sutured IOLs. You know, I think the other thing that I've learned with these IOL cases is, you know, it's great that you did have records, but oftentimes these patients who have had complicated IOL cases before, you know, haven't been seen in your system. And I feel like there's always surprises with these cases, and it's just good to sort of be on your guard, because you're not sure sometimes what you're going to encounter. But I think just sort of having a plan and then readjusting as the case goes on is good.
So
Yeah, I
I'll
was
tell you,
telling Eddie, so many times we want the op note and we don't have the op note. He had the op note, but didn't know to look at it. So I think that was a teaching point. And the second thing is you did know that he had some sort of IOL exchange, right? And so like, what possible IOL exchanges could he have had? You know, it's not a sulcus because you don't see blue haptics. So it has to be some kind of scleral fixated, whether it was a Yamani or an acreose or an Invista. So you know something is funky. But I think when you're in the OR to fix an RD, you're so tunnel visioned, like I'm doing this RD, I'm gonna do the buckle, I'm gonna do the vit. You like totally forget about everything else. And I think that is something that you have to always kind of take a step back and see the forest of the trees and figure out what is the best for this eye, not just I'm in like my routine, I'm gonna fix an RD and get it done.
Right.
So if you're going to open, and you had to open, and, you know, granted, primary vit makes a ton of sense, but I think we all agree. I think I always say that, you know, I start my opening farther away than where it should have been. I posteriorly dissect first. I don't bring it all the way up to the limbus in that area until I have free, like, you know, I kind of just go posterior to anteriorly and gently kind of dissect over so that I can see it. And then I will bring it up to the limbus. You still can catch it. It's still very possible. And sometimes these have already dislocated before. Maybe that's the reason of the detachment. You know, maybe this thing was already like kind of slipping down and caused break. It doesn't look like in this, but you know, you make yourself feel better, Eddie. Let's just say it. So like, you know, that had to happen anyway. But I think, you know, if you're going to do this, you know, knowing ahead of time, I just moved I wouldn't have done it at the horizontals. I wouldn't have start my perimeter there. I mean, I would have probably started a little more superior and gone posteriorly.
Yeah. Yeah, I agree. And I think the issue here was I just had no idea and didn't know to expect that. It was like, it was kind of a case of, if anyone's note I would think is the most comprehensive, it would be our uveitis service, and I got kind of tricked into that and pulled into that, and now I know I need to look through.
Don't
like,
blame the
all
uveitis
of that.
service, bro. Don't
Oh,
start going there.
uveitis service.
Their
Just
notes are
like-
very,
Ooh,
very
burn,
comprehensive.
burn.
Very
Those tend to be
comprehensive.
longer. Yeah, longer. So I'll say this. I think you know, a really good takeaway from this case is, you know, just really be aware that these patients, a lot of patients now have IOLs that are, you know, fixated, and I think you just have to think about that now. I'm going to
Yeah.
think about it. It's good stuff.
So just briefly, I don't know if we have like 2 minutes,
We
but
have
I'll
5
cover-
minutes. Yeah, go ahead.
So we think about opacification of the acroeos lens. You know, there's a couple of case series out there. I tried to summarize them here. They weren't very large. There's the biggest one I saw from the brief search was 12 eyes from 2020 that underwent RD repair after secondary implantation of the AO60. Opacification developed in 5 eyes total, and it didn't matter if they had gas or oil. And this doesn't happen right away. It typically happens like weeks to months after. So same thing I saw in this other case series of 2. It was post-op week 6 and post-op month 2. And then there was a series in JVRD of 257 AO60s. Of them, 3 opacified because of dissect, and then 1, I think Dr. Leung mentioned, the RD with the dissect, where there's gas on both sides, and then 1 just from an RD. So the opacifications is actually calcification, and so here's a alizarin red stain, which stains calcium of an explanted AO60, and it seems to happen from gas or from oil, and no one seems to know actually why it happens, why calcifications happen. So that's another thought about putting in AO60s in general. I don't know what the other faculty's thoughts are about this.
Yeah, I mean, I love the AO60. I think it's my favorite lens to put in, and I think it's just the stability. This is an issue. I don't want to say that I don't see it very often, because I'm gonna get burned in like the next 2 weeks. I'm gonna see like 12.
More of.
But yeah, exactly. You know, I've seen 1 in like 12 years. It does happen, of course, and if you need to, you take it out. But you know, taking these out, you know, because of the suture, you made it look easy, Eddie. Sometimes it's not so easy to dislocate these things and take them out, since it's actually to cut the eyelid itself. So you know, if it does occur, I take them out. I put in ACIOL, as someone's mentioned, or you know, AFAKA, or you know, put in MX60. But I haven't seen too many.
BNL just needs to bring the European AO60 over.
Yeah, I think that would be the solution, and Peter's been mentioning it in the chat here. There is a lens that would work well for us, and it's just been, you know, it's something that hasn't reached us yet here in the States.
And so that European AO60 is not hydrophilic then?
Correct, it's hydrophobic.
That would be much.
Interesting.
That'd be awesome.
Awesome. Well,
Thank you guys.
great job, Eddie.
Kat, go ahead and take it away.
All right. So moving
Nice job,
into our
Eddie, by the
last-
way.
Nice job, Eddie. Thanks so much for showing us that challenging case. We're going to move on to our last case. Danny Mamo is our other awesome second-year fellow at Cole, and he's going to be presenting. He did his residency at the University of Minnesota, did his fellowship here with us at Cole, and we're so excited that he's going to be joining our faculty after he graduates fellowship. Danny, could you present your awesome video for us?
Thanks, Kat, and thanks to all the Stanford and Cole faculty. So I'm a different type of technique today to round out the day. This is a case that I think everyone should have in their arsenal. So this is a dislocated three-piece IOL and artificial iris complex. This is a 49-year-old guy. He had a history of a bungee cord accident to the left eye in 2017. And then he was seen by an anterior segment surgeon for a traumatic cataract and an iridodialysis. And this was a complex ant-seg surgeon, so he fixed this all in one go. He took a three-piece IOL and then got an artificial iris, punched a pupil, a hole into the artificial iris, and then sutured the three-piece IOL to that iris, and then inserted it into the eye, and then used Hoffman pockets, used like the modified Agrawal technique to externalize the haptics.
Hey, Danny, I'm sorry to interrupt. Are you screen sharing right now, bro? I don't think anyone's seeing anything.
Oh, I'm sorry.
We're just seeing a
It-
black
it-
screen.
He is. He
it was
just hasn't
great.
started the
It was
video yet.
it was a great soliloquy, but
It was it's only the first slide of PowerPoint, so we're good.
Okay.
So
Thank you.
he explanted the haptics 180 degrees apart from each other, and actually sutured the haptics with proline sutures to the sclera.
You're making this up.
No. So
I love this story.
5 years later, he comes to us with a dislocated IOL and artificial iris complex. His vision's count fingers, but with a +20 lens, we get him to 20/20. And then reviewing the records, it is his three-piece IOL, the Zeiss CT Lucia at the time, that he did suture to this artificial iris. Posterior segment looks okay. Obviously, this old iris trauma here. So how would everybody in the panel fix this case or approach this case?
I would love to hear my co-faculty's opinion on this one. This one was fun to discuss. I think the discussion's half the fun.
How flexible are these things? They should be able to go through a small wound, right? They're foldable and manipulatable.
The artificial iris? It should be, but remember, this is sutured to the actual IOL. It's not.
Do you know is this the custom flex artificial iris?
Is that the new one?
Yeah, it's the one that's made in Germany.
Yeah,
Because they're very thin and very flexible. So that one, you could even just leave it on the IOL potentially and take the IOL out whatever way you want. But I don't know what this one is. So if you don't know what it is, it's hard. I would definitely try to find out prior to surgery exactly what was put in there and the properties of the iris.
Yeah, I know it's not the new custom flex, but I don't know exactly what material this was. His op note, which we did have, his op note didn't it specified the lens. It did not specify what type of artificial iris. He just said he punched an artificial iris.
So, one thought is if it is connected to the IOL is, if you can bring this up into the pupil plane, separate the two and then take them out piece by piece, because I'm just guessing you're not going to put this thing back in. So.
Okay.
How old is the patient?
Could you just somehow reposition the whole complex by finding out where you need to put the haptic and making a new groove through the sclera and explanting that, or bringing the haptic out through that and just kind of redoing what his surgery was? Is that an option?
Do you want to keep this in place, Steve? Save it?
I'm asking. I mean, it would be the nicest solution if you think that's possible, because you don't have to take anything out. He still has an iris, but I don't know. I'm asking. Is that something anyone would consider?
I was thinking the same thing, but then I've never dealt with anything like this before, so I wasn't sure if that was even a possibility.
I think you all are just making phenomenal points. This was the discussion that Dr. Mavo and I had as we were discussing this case. So let's see what we did, Danny. What'd you do actually? Danny actually made the call on this one. So yeah, got all the records on this one because this one was a, we were trying to figure out what we were dealing with. We didn't know. The patient didn't know. Danny's going to tell you more about the patient here in a second, but this one was where getting everything as much as we could, like information wise, because we didn't know what kind of lens this was. And it took a little bit of research to figure out this was actually the first generation CT Lucia.
So we thought it would be best to try to refixate it in this guy's young eye. And as we were rolling the patient back, he had informed us right before he went under anesthesia that he actually paid $20,000 cash for this. And he really wanted us to try to save this IOL iris complex. And if we couldn't save it, he actually wanted us to, I don't know what he wanted to do with it, but he wanted to he wanted us to put what we took out into a small little cup for him because he paid $20,000 for it. So we take him to the OR with the goal of trying to rescue it. And if it fails, then we do a scleral sutured IOL and then send him to another ANSEG surgeon for an artificial iris, maybe the new custom flex later on. So here we're using a Q-tip to poke the nasal haptic, which still looks like it's in place. So the temporal haptic is what seems to have dislocated. So we measure the limbus to haptic distance because we want to match it temporally. So basically what we're going to try to do is the modified Yamani technique that John Prenner and George Williams kind of adapted for using cannulas and max grip forceps. So to do this technique, you have to be 180 degrees apart for your haptics. And then the distance of each haptic from the limbus also has to be the exact same. And then your tunnel on each side has to be the same, as we'll see here shortly. So this distance, I think, was about like 1.8 or something. So we used a toric marker to get 180. And then we did 1.8 on the other side. Put our infusion in. So we're matching the other side. And then the haptic, we could tell, was going to come out superiorly. So we matched our tunnel to be the same distance superiorly. And then one technique I really liked is we marked on the 27 gauge trocar the same distance, because when you're making your tunnel and beveling in, you're kind of guessing a little bit as to where the tip of the trocar is. So I just tunneled in until I saw my purple marker. It required less thinking, which I like to do, think less. So this is going to go in, and right when I get to the purple marker, I stop. And then I know
It's a
that
really nice pearl.
And then I know that I can dive in and tunnel. So he had a mild anterior vitrectomy from the other surgeon. So we completed the vitrectomy, knowing that we're going to be using forceps to grab this haptic here. So don't want to drag any vit during this part. So carefully completing the vitrectomy here.
If he paid $20,000 out of pocket, I think he should have bought himself a full vitrectomy beforehand.
Obviously careful not to cut the haptic, which would obviously change the case entirely. So here, I'm not showing it because we're still under the recite, but I take my 25 gauge cutter out and then put 27 gauge max grip forceps through the temporal 27 gauge cannula. So this is the 27 gauge max grip forcep. I grab the tip of the CT Lucia haptic. And before externalizing it, you don't want to just pull the haptic through the cannula. So you need to take 0.12s and remove the cannula up the shaft of the forcep. Otherwise, you're very prone to get haptic dislocation. And then we externalize the haptic, grab it with smooth forceps. And then we use low temp cautery to create a bulb. And then, before we did that, as we're holding this, that nasal haptic ends up dislocating. And obviously we weren't even touching that side. So just with gentle manipulation, you could see that that nasal haptic also wasn't very secure. Thanks, Sunil, taking one for the team. So basically we're just gonna repeat the other side here. So we already knew the measurement here, about 1.8. We recreate our tunnel. Now here, this is nasal. So the nose is, top right of your screen. So this one is just a little bit harder just because the nose is in the way there, but you make a flat entry, go all the way until my purple mark, and then tunnel in. And then we complete the vit on this side, making sure that we're not going to drag vit when we go in. And here we put 27 gauge forceps through the 27 gauge cannula and repeat the same maneuver. You can imagine my hands here because the nose is in the way. So this one was a little harder to externalize. Obviously, this is at the 3 and 9 because that's where we were left at the start of the surgery. I think many times when people do this case from scratch, they tend to avoid the 3 and 9 to make it easier to get the nose out of the way. But here we take the cannula up the shaft and then externalize the haptic again.
And if you're really struggling with the position, you can actually just move over and sit temporally, and it makes your hand position much easier for that nasal one.
Oh,
And
that's a great tip.
it's an easy trick you can use.
That's a great tip. And then actually a few of the other fellows that I know are on this call, a week or two after this. So Alcon has new forceps, I forget the name, their new brand, where the shaft of the bucket handle is a lot smaller. And then also you can actually take the bucket handle totally off the forcep. So it makes just a very thin forcep that can also help you maneuver in tight corners. This looks very well centered, but it was slightly tilted because this inferior artificial iris actually is supposed to be posterior to his remaining iris there. So we gently take Visco and reposition this right behind the iris. And then we take low temp cautery. You don't want to touch the haptic. You just go close and the heat creates a nice bulb. Using 27 gauge is nice for this. And then you gently tuck it underneath the conjunctiva. And had to suture the wounds here. I can tunnel the haptic cannulas, but apparently not the tracheotomy cannulas. And then here is a post-op month 1. The vision's 2025. And it's been about, I don't know, 5 months now. He hasn't come back, so I assume that the lens is still centered.
He came back for his month 4 visit, month 3 visit. He was he was complaining that he was only 2025.
That's where it's hard not to laugh in front of people. It's like, dude, you have no idea how much you should be happy.
Yeah, it was
That's fantastic.
I mean, got everything he wanted, and it was fantastic. Let me give complete credit. Danny Memo did that whole thing, man. Nice job. I mean, came up with the ideas throughout. I mean, we were discussing it, and forums like this, it's good to see like kind of a technique, and we obviously made it more difficult, but it was going to happen. I think, once we pulled,
all these cases today had a certain level of depression. This was like holiday cheer at the end. Like I feel good about like life.
So it didn't look like he made a bulbs on the end, and that's probably why it dislocated, right?
Yeah.
So the previous technique
to make bulbs, I think he just wanted to do the Agrawal, where he took a prolene suture and sutured it to the sclera.
Yeah.
So if we read the op note, he actually had a lot of trouble like tunneling, putting this into like a tunnel. So he created a pocket. And I think Kabul, you were asking why we chose that length. We were trying to match it to the other, what we read on the previous note, because we only thought we had to do it on one side. So we thought we could make it a similar length. And then, you know, you read the op note and he had a lot of difficulty doing it. So it just.
So here's a question. You know, should they have not have gone at 3 and 9, but actually been a little bit off axis? Because if there was issues, if that was fibrotic, you know, taking Sumit's idea of sitting in a not superior position, you know, why not just go a little bit off 3 and 9, so you avoid all the previous scarring or whatever, and you know, false passages.
I think
Well,
that would be
it's different.
ideal. I think the hard thing that you were stuck with is it was already it was still in position nasally, right, when you started.
Right.
So you were sort of committed
That's
to
right.
that
Okay,
clock
right,
hour.
right.
Yeah, if the whole thing were dislocated,
Yeah,
yes.
then
Yeah.
Well, I guess
So we
I guess the question is also whether you would plan to dislocate the other haptic purposefully. I think this worked out well because it did. So you end up being sure that you have them exactly 180 degrees apart when you do it. And I'm wondering if that would have been, you know, if planning for that would have been good. And had that not happened, you might have been in trouble because the other end didn't have a bulb and he could have dislocated, like, you know, a month, let me be really unhappy on his money back.
But then also, I mean, again, it dislocated on its own, so you knew it was loose, but the last thing you want to do is like plan somewhere else and then be tugging on this haptic and have it break on you or cause other issues. And then you're really like up a creek without a paddle.
Yeah,
Still
I
is-
think there's a lot of fortunate things in this case, right? The fortunate that they're CT Lucias, where the haptics don't tend to break and stuff like that. It was fortunate that that other haptic slid out when it did rather than another. So I think you guys did a fantastic job. But you know, good skills and good luck are never bad things to have.
So Neil, as the attending, you know, you were chasing those haptics that were externalized, and you know, it gets kind of like, it's a lot of pressure because, you know, just any motion to the other side of the IOL and you worry about that going back into the tunnel.
Prithvi, I learned from operating with you. I just close my eyes most of the time.
Very
That's the
nice.
best thing to
Well,
do.
thank goodness Danny was operating, because you were no help, obviously.
Clearly, you know, to all the points that have been made, I think, you know, one of the take-home points for me on this, we didn't know really what we were walking into, but I think knowing that some case had been done with a previous like glue technique and no bulbs, I would have planned to dislocate like both haptics, and as I think everyone mentioned here, probably change the position. So yeah, you know, because now seeing how easy it came out, I think if this happened again and I had a C2 Lucia, or I knew I had a C2 Lucia, and I would actually try to do that. So
Danny, did you consider that you'd have to, you know, if the haptics broke and you'd have to explant this whole thing, like, did you consider, I'm gonna just rinse off this implant and reattach it to something and put a new CT Lucia in? Was that on your list?
I think it would have folded, and I think we'd have explanted it like we do other stuff, and we probably would have done a scleral sutured IOL.
I would have charged them. I would have
all
charged
those
$20,000
Byers
bucks.
implants fold, right? I mean, they're all foldable. They actually scroll them, I think. And I don't know if they would, if it was something that was so large it had to be put in with a huge wound, they probably wouldn't have put a CT Lucia, and they would have put a, you know, a CZ70 or something. So I think you're right. The chances are extremely high that that's a foldable implant.
Hey, Danny, I don't have any further comments. I mean, I think you both did a fantastic job with that case. One thing I would say, when you're doing the Imani technique, the modified Imani technique primarily, not really in this case, it doesn't apply to this case, but something that I found is helpful in those is doing it with 3 ports rather than with 5, and just positioning your trocars 180 degrees apart as far back from the limbus as you would like them to be is a nice technique when you're doing it primarily. But for this case, I mean, amazing job, I think.
You do 25 gauge?
Yeah. Well, 27 gauge, I think they found leads to less dislocation, but 25 gauge is easier when you're using a haptic that might not be indestructible, because it's easier to break a MA60 AC haptic when you're going through a 27 gauge cannula. If you have a 25 gauge cannula, it's a little more forgiving, but either one, people do both. Yeah, but that was a great case. Awesome job, both of you.
Thanks for the
Well
comment.
done. Great comments. So Sunil, are we calling it a year?
I think we're calling the year. Final words, Dr. Musmajaya?
Thank you very much. Thank you for everyone for taking their time to join us this evening. It's a great mix of complicated lens scenarios. I think we learned each case had great takeaway points that hopefully will all make us better surgeons. And we all want to dislocate a artificial iris now, just to put it back again, if we could. Thank you very much to the iVista team for putting this together. And please tell your other fellows who are out there that may not have joined in. I think this is a great opportunity for us to share cases. Sunil, our next date is February 28th is our next date. February 28th.
Yeah.
Can't wait. So we'll have announcements of our cases, and looking forward to more adventures. Everyone have a very safe, healthy, and happy holidays. Spend time with your families and take time off, except for Sunil's fellows, who will be doing his dirty work, all the way through. So
Uveitis notes until the end of the year. Thank you, everybody. Have a great night.
take care.